Hi, my name is Nadia Lopez, and today I'm gonna talk about Cabozantiniv versus Everolimus in advanced renal cell carcinoma. This assignment is medical English. First, a definition. Cabozantiniv is an oral small molecule tyrosine kinase inhibitor that targets vascular endothelial growth factor receptor, also known as VEGFR, as well as MET and NAXL, each of which has been implicated in the pathobiology of metastatic renal cell carcinoma, or in the development of resistance to anti-angiogenic drugs.
Some of the key take-home messages are that cabozantinib actually has a pretty similar side effect profile compared to the other TKIs that we're familiar with, like sunitinib and pazopanib, and we do have data comparing it head-to-head with sunitinib from cabozan, so we have some idea of how side effects is different and similar. So one of the side effects that's a lot more frequent with cabozantinib is diarrhea, and it's actually the most common reason that patients will require dose reduction. So I think one of the key take-home messages is when we treat patients with advanced kidney cancer with cabozantinib, we want to watch out for diarrhea, and we want to be ready to hold the drug and dose reduce if we need to.
So, in this study, we're going to evaluate the efficacy of cabozantinib as compared with everolimus in patients with renal cell carcinoma that had progressed after VEGFR targeted therapy. But what is renal cell carcinoma? Renal cell carcinoma is a kidney cancer that originates in the lining of the proximal convoluted tubule, a part of the very small tubes in the kidney that transport primary urine. Renal cell carcinoma is the most common type of kidney cancer in adults, responsible for approximately 90 to 95% of cases in the world.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Okay, so now we have applications in medicine. First, we have the primary endpoint. The primary endpoint was duration of progression-free survival. This is defined as the interval between the dates of randomization and first documentation of disease progression. This means when we diagnosed the renal cell carcinoma, this interval of time when we treat that. The secondary endpoint is the secondary efficacy endpoints where duration of overall survival and objective response rate. Tumor response and progression were assessed according to response evaluation criteria in solid tumors. This means the overall survival when we had treated the renal cell carcinoma. This is a resume of the study. We have advanced renal cell carcinoma. Then we randomize the patients and we administrate Cabozantiniv and Everolimus to prove the overall survival population. What are the pros and the cons? The pros: a progression-free survival benefit associated with Cabozantiniv was consistently observed in pre-specified groups. Another pro is that axinitive is also an option as a second-line treatment for patients with renal cell carcinoma, given the results of the phase 3 AXIS trial, which showed a benefit in progression-free survival. Now we have the cons. A con is that adverse event occurred in 9% of the patients who received Cabozantiniv and in 10% of those who received Everolimus. We have the adverse effects explained in a video.
There are two basic side effects. One is a fatigue. Some people call it mental fogginess. And the other is an intestinal nausea, vomiting, diarrhea, constipation side effect. We didn't usually talk about constipation as being a drug side effect. Many of the patients complain about constipation alternating with diarrhea, which is an unusual side effect. And then there are the other side effects that are similar to the VEGF inhibiting side effects. They include a hoarse voice, skin changes, ulcers on the fingers and toes, sometimes on the heels, and then a serious and on very rare occasions fatal side effects, which include blood vessel damage, one of which could include intestinal perforation, because small blood vessels feeding the intestines can die, and you basically get a heart attack in the small bowel. There have been a few reports of heart attacks as well.
The last con is that the most common grade 3 or 4 adverse events with cabozantinib were hypertension, diarrhea, and fatigue, and with everolimus were anemia, fatigue, and hyperglycemia.
Cabozantinib has been approved in Europe and is now reimbursed in many countries in second-line setting or more for patients who have failed prior VEGF inhibition. It is a potent VEGFR TKI, so we are familiar with the, let's say, safety with this agent. And we have to handle that as we would for any potent VEGFR TKI. We have to be careful about blood pressure management and prescribe the right drug in case of hypertension, high blood pressure. We have to be careful about the hand-foot syndrome. This is something we're familiar with. We have to be careful about diarrhea, fatigue, all those side effects we are quite familiar with already. The only thing is that this drug does require some dose reduction. In the pivotal study, for instance, it was almost 2 patients out of 3 that required a dose reduction because of safety. Nevertheless, it is a potent, very active VEGFR TKI, and we're happy to offer this agent to our patient given its efficacy in terms of response rate, progression-free survival, and overall survival.
Now we have the issue applied in Ecuador. In Ecuador, cabozantinib or everolimus have not been used for renal cell carcinoma, and there are not studies that shows the benefits or the efficacy in these drugs. However, these drugs are used as a combination between raloxifene and cabozantinib for breast cancer, and in this area, it have shown benefit results. However, cabozantinib in Ecuador are not used for renal cell carcinoma. And to ending the conclusion, in the study, we can see a Kaplan-Meier overall survival with cabozantinib and everolimus in 24 months and the percent of overall survival. In conclusion, cabozantinib, a multi-targeted MET, VEGFR, and AXL tyrosine kinase inhibitor, was associated with longer progression-free survival as compared with everolimus among patients with renal cell carcinoma that had progressed after prior VEGFR inhibitor therapy. A strong trend toward longer overall survival with cabozantinib than with everolimus was shown in an interim analysis. A majority of patients who received cabozantinib required dose reductions, as we can see in the video, to manage adverse events, as told in the video. And that's it. Thank you.